I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com.
The People's Pharmacy podcast is supported in part by CocoVia. CocoVia cocoflavanols support both cardiovascular health and cognitive function by promoting healthy blood flow, transporting oxygen and nutrients to vital organs and muscles, including your heart and brain.
CocoVia now comes in an even more concentrated formula with 450 milligrams of cocoflavanols, 5 times more than the leading dark chocolate bar and 15 times more than the leading cocoa powder.
CocoVia has a proprietary process that preserves cocoflavanols at the highest levels, and the product undergoes rigorous testing at every stage, which allows them to guarantee the highest level of cocoflavanols per serving and to provide the purest, highest quality product possible.
People's Pharmacy listeners can now try CocoVia for 25% off by using the code Peoples25 at cocavia.com. That's COCOAVIA.com. How often do you exercise? Does work or bad weather interfere with your good intentions? Exercise is good medicine. This is the People's Pharmacy with Terry and Joe Graydon.
Doctors may not be aware that exercise can be as powerful as prescription drugs for some conditions. Our guest, Dr. Carrie Stewart, is an expert in exercise training for heart disease, diabetes, hypertension, and cancer. He suggests that doctors should prescribe exercise just as they prescribe medications.
The general advice to exercise more is typically useless because without specific instructions, the patient is unlikely to do anything.
Coming up on the People's Pharmacy, exercise as medicine. In the People's Pharmacy Health Headlines, the Food and Drug Administration has announced 2 drug recalls this week. Sandoz is pulling all of its prescription ranitidine capsules because testing detected a suspected carcinogen called NDMA. Health authorities in Canada, much of Europe, and Taiwan have already issued recalls for Zantac and generic ranitidine. The FDA has not yet asked other U.S. distributors to pull their ranitidine products. Ranitidine is an H2 antagonist used to treat ulcers and acid reflux. In addition, Torrent Pharmaceuticals is recalling multiple lots of the blood pressure drug losartan. This action is related to detection of the impurity NMBA. This nitrosamine compound is also a probable human carcinogen. Torrent has now recalled more than 300 lots of blood pressure medicines during the past year.
Aspirin has been getting mixed reviews lately. Earlier this year, the American Heart Association and the American College of Cardiology said that low-dose aspirin should only be used by older people at high risk of strokes or heart attacks. Others, they said, would be more likely to be harmed. Now, though, researchers from Roswell Park Comprehensive Cancer Center report that patients with head and neck cancer have a better chance of survival if they take low-dose aspirin while undergoing treatment. An additional 8% of patients taking the 81 milligram daily dose were still alive 5 years after treatment compared to those not taking aspirin. A different study at Roswell Park compared aspirin versus no aspirin among 164 patients being treated for early-stage non-small cell lung cancer. The patients got precision radiation therapy. 2 years after treatment, 57% of those taking low-dose aspirin were still alive compared to 48% of those who did not take the drug. The U.S. Preventive Services Task Force has also recommended that obstetricians consider recommending low-dose aspirin to patients at risk of preeclampsia. This complication of pregnancy can be extremely serious for both mother and baby. Women taking low-dose aspirin are 24% less likely to develop preeclampsia.
Scientists suggest that the Puerto Rican culinary tradition of incorporating sofrito into many dishes might help explain a lower rate of breast cancer there. This condiment is made with onions, garlic, peppers, cilantro, and a related herb, racao. Epidemiologists found that Puerto Rican women who ate lots of garlic and onions, including sofrito, were 67% less likely to get breast cancer than those who never ate sofrito. The total intake of onions and garlic was important, not only the use of sofrito. The researchers point out that onions and garlic are rich in flavonols and sulfur-containing compounds that have anti-cancer activity.
Despite lots of information about how to eat healthfully, Americans are still getting too much of their energy from low-quality carbohydrates. Nutrition scientists drew this conclusion from analyzing Nutrition, Health, and Examination Survey data from 1999 to 2016. Although the American diet got a little better over that time frame, the change was modest. Only 9% of calories in a typical American diet come from whole fruits and whole grains. About 42% comes from highly refined grains, added sugar, and starchy vegetables such as potatoes. The estimated healthy eating index went from 55.7 to 57.7. Although this change is statistically significant, it leaves plenty of room for improvement.
Americans are often exhorted to walk on the sunny side or look for the silver lining. Can such a cheery attitude influence your health? A recent meta-analysis in JAMA Network Open suggests that optimistic individuals are less likely to suffer heart attacks, strokes, angina, and death from cardiovascular causes. The analysis included 15 studies with a total of more than 200,000 participants. A pessimistic attitude increased people's risk of cardiac problems. The author suggests that health professionals might want to come up with interventions to reduce pessimism and promote optimism, especially in cardiac rehab programs. They express the hope that their study might stimulate research into the heart benefits of a sense of purpose or gratitude. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. Public health experts have long offered Americans simple advice to stay healthy. Don't smoke, eat a well-balanced diet, and get enough exercise. Simple is not the same as easy. As they say, the devil is in the details. In other episodes of the People's Pharmacy, we've talked about diet and how to eat right. What is enough exercise, and what type of exercise might be best for you? How would you know if you're getting enough?
To help us learn more about how we can use exercise as medicine, we're talking with two experts. Dr. Carrie Stewart is Director of Clinical and Research Exercise Physiology at Johns Hopkins University School of Medicine. He's also Professor of Medicine in the Cardiology Division. Dr. Samir Dixit is Medical Director of the Johns Hopkins Orthopedic Clinic at Green Spring Station. He's also an Assistant Professor of Orthopedic Surgery at Johns Hopkins.
Welcome to the People's Pharmacy, Dr. Carrie Stewart.
Hi, and thanks for having me.
And welcome to you also, Dr. Samir Dixit.
Thank you, Terry, and it's a pleasure being here.
I'd like to start with you, Dr. Stewart, because Johns Hopkins University School of Medicine has really been at the forefront of the idea of exercise as medicine. Can you tell me a little bit about how that concept gets really integrated into your program and what it means both for health professionals and patients?
Well, I think it's based on the fact that exercise has an important role in the treatment and the prevention of many, many diseases. And it should be part of medical care, which it typically has not been. But by giving the emphasis that exercise is like medicine, we're hoping to achieve the recognition that it should be thought of as part of care for almost all patients.
Dr. Stewart, I think the one area in which people have become familiar with the idea of prescribed exercise as medicine is in rehabilitation from heart attacks. Is exercise also helpful for other cardiovascular diseases, for example, heart failure?
Sure. Heart failure is one of the diseases or diagnoses where people would benefit from participating in cardiac rehab. And more recently, the Medicare, or CMS, has approved participation in cardiac rehab for people with lower extremity peripheral arterial disease, another form of cardiovascular disease that affects about 12 to 15 million people.
We should just get a clarification, lower extremity peripheral arterial disease. In general terms, what does that mean?
It's like having angina of the legs. There's a limited blood supply, and when people exercise, they get cramps or pain in their legs typically as a symptom, or they just get undue fatigue where they can't continue to do exercise. And it's due to blockages in the arteries of the legs, just like a blockage in the heart would cause a heart attack.
So you say they get pain, they can't continue to do exercise, and you're saying exercise is the answer?
Absolutely.
Sounds counterintuitive.
Absolutely. And that's why that's one of our tasks, is to explain that, particularly to patients who are usually the message to people when you get pain with exercise is to stop. But in that particular instance, keep going is the message, because that stimulates a variety of physiological responses that over time results in less pain and being able to do more work.
Dr. Dixit, you are a professor of orthopedic surgery, medicine, and physical medicine and rehabilitation. And I bet you have to deal with a lot of pain patients, people who either are athletes and end up with bad knees or bad hips or, something hurting, and they want to get back into their exercise regimen, but also people like the ones that Dr. Stewart is referring to, people who, for example, have pain because of some cardiovascular complication, or maybe because of diabetes or overweight. How do we prevent pain from interfering with an exercise program when, as Terry says, it seems counterintuitive? Exercise when it hurts? No, that doesn't make sense.
Well, I think there's a couple points. One is that what Dr. Stewart was talking about with peripheral vascular disease, exercise is the treatment and is how we treat that particular entity. In other forms of sort of what you're referring to, when other people have other forms of pain, as a sports medicine physician, I can sometimes try a workaround. For example, have a runner with knee pain. I can talk to them about other forms of activity, for example, biking or swimming, which put less stress on the knee. So there are, I think there's a couple points. One is to appropriately address the reason for their pain and try and help the patient with their pain in a reasonable manner. And then the other point that I'd like to make is, as a sports medicine physician, my job is to keep the patient active, because, again, Dr. Stewart talked about something that was more of a treatment, but exercise is actually preventative of a lot of health issues, and it's very important to keep people that are already active, have them continue to be active.
Well, I think that there's also room for education of your colleagues, because for a long time, I think physicians didn't always encourage their patients with cardiovascular problems to exercise. I mean, if they had, for example, congestive heart failure, people were like, gee, I really can't climb stairs. I really can't walk around the block. And that's true also of people with peripheral artery disease, like, it just doesn't feel good. And that's, of course, a great excuse for sitting in the armchair and watching television. So how do we get your colleagues to be able to encourage their patients to keep moving?
So I think a lot of our job as educators is to educate our colleagues, particularly when they're in training, as to the benefits of exercise. And I think the evidence for exercise as preventative for health issues is very clear and very strong. You can make the argument really with coronary artery disease alone, which is, the top killer of people in our country. But there are other medical issues that can affect positively as well: stroke, hypertension, diabetes, certain cancers, depression, decreases the risk of falls. And those are very clear studies. There's no ambiguity. There are other medical issues that we deal with that there's more moderate evidence for the fact that it helps to prevent those issues. So I think, just to point that out and educate our peers is probably the number one step. I think we spend a lot of times on reacting to people's health issues, their symptoms, and sort of what has happened downstream. I think it's also important to talk about the preventative aspects of lifestyle and particularly exercise in this case.
Dr. Stewart, I suspect that a lot of health professionals really do understand how important exercise is for a lot of health conditions, and that exercise can be as powerful as prescription medicines.
That's actually one challenge that we have, is to get that message across to a broader number of people in medicine who treat patients. And one of the challenges I think that we have, for example, is that most of the advice given to people, for example, on discharge from the hospital, might be don't lift more than 10. Someone had a heart attack. Don't lift more than 10 pounds. Don't do this, don't do that, as opposed to saying, let's start with 5 pounds and gradually move up. So we have to shift the thinking from the advice being what not to do, but what to do in a progressive and safe way.
That's a really interesting change in perspective, because I think some people hear don't lift more than 10 pounds. The doctor may even put a time limit on it and say for the next 2 or 3 weeks, don't lift more than 10 pounds. The patient may just hear don't lift more than 10 pounds, and that might be how they behave for a long time.
Many years at times.
How can we change that?
Well, it's really the educational efforts that are going on and programs like we've put on at Hopkins, this symposium called Exercise is Medicine, is to try to educate health providers about the benefits of exercise and how to prescribe it in a healthy way so that the patient at least is motivated initially, because their doctor told them to do it, to get involved in some type of activity program.
How does a doctor prescribe exercise? And I'd like to hear from Dr. Dixit as well.
Yeah, so I think it's like a lot of what we do in medicine. It's important to know your patient and know their lifestyle, know what they're doing day to day. I think our barriers to exercise are variable, and I think we need to get to the individual patient's needs. So what common things are, a lot of people don't know where to start. If you haven't exercised for a long period of time, it's hard to know where to start. And I think one of the things you need to do is just sit down and talk to your patient about their life and what if they're working or what they're doing day to day, and ways to kind of squeeze in even mild forms of exercise to start. So even a 10-minute walk at lunch or before you go to work, that can add up over the course of a week, and that's what we're really talking about. I think a lot of people think of exercise as sort of, that high-intensity thing that you see on TV, and that's not where you need to start, and that's not necessary for the health benefit of exercise. I think we can start much smaller, and I think you have to get to know your patient and what they enjoy doing. Do they like swimming? Do they have access to a pool? Do they enjoy biking, running? Do they have a park? Do they like hiking? Just sort of get to know them and what they've done in their life and work within those parameters to help them find time to exercise.
You're listening to Dr. Samir Dixit, Medical Director of the Johns Hopkins Orthopedic Clinic at Green Springs Station. He's Assistant Professor of Orthopedic Surgery at Johns Hopkins School of Medicine. You're also listening to Dr. Carrie Stewart, Director of Clinical and Research Exercise Physiology at Johns Hopkins University School of Medicine. He's also Professor of Medicine in the Cardiology Division.
I love the idea of finding something that you enjoy, because if you don't like it, you won't do it. After the break, we're going to find out how doctors can help patients implement an exercise plan they really will follow.
Can exercise be used to prevent heart attacks as well as to recover afterwards?
Lots of people count their steps every day. Does this make sense?
Other people are eager to exercise soon after a heart attack. But are there ways to stay motivated to keep it up for years?
And can you find personalized exercise programs for particular health concerns?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
The People's Pharmacy podcast is sponsored in part by Kaya Biotics. KAYA Biotics offers the first probiotics which are both certified organic and hypoallergenic.
All probiotics are produced in Germany under laboratory conditions with high-quality ingredients and under strict regulatory oversight.
The 3 available formulas are created for very specific purposes, such as strengthening the immune system, fighting yeast infections, and helping with weight loss.
To learn more about Kaya Biotics probiotics and the important topic of gut health, you can visit their website, KayaBiotics.com. That's KAYA Biotics.com. Use the discount code PEOPLE for $10 off your first purchase. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon.
The People's Pharmacy is brought to you in part by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
And by CocaVia, the maker of high-potency cocoflavanol supplements that support cognitive and cardiovascular health. More information at cocavia.com. That's COCOAVIA.com.
Today we're discussing how you can use exercise as medicine. We've all heard that exercise is good for the heart. New research suggests it's also good for the brain. How can we harness the power of exercise to overcome many of our most debilitating diseases?
We have 2 guests today. One, Dr. Carrie Stewart, is Director of Clinical and Research Exercise Physiology at Johns Hopkins University School of Medicine. He's also Professor of Medicine in the Cardiology Division.
We're also speaking with Dr. Samir Dixit, Medical Director of the Johns Hopkins Orthopedic Clinic at Green Springs Station. He's Assistant Professor of Orthopedic Surgery at Johns Hopkins School of Medicine.
Dr. Stewart, I suspect that a lot of physicians tell their patients, you need to exercise more. Maybe you need to lose weight, eat less, exercise more. And sometimes that comes with a kind of a frown or a wagging of the finger. Like, you're 15 or 20 pounds overweight, you have diabetes and high blood pressure, you really need to exercise more. And then the patient leaves the office thinking, oh, yeah, I've heard this 100 times. Of course I know I need to exercise more and lose 15 pounds. But that's not very helpful. How do you actually implement a program? How do you help your colleagues come up with strategies that will actually lead to behavior change and then maintain that kind of change so that exercise is really part of the program? And how do hospitals help, whether it's a cancer hospital or whether it's a cardiovascular wing of a hospital? Everybody's good when it comes to stents and when it comes to medications, but how do they make exercise part of the program and really get it entrenched?
The general advice to exercise more is typically useless because without specific instructions, the patient is unlikely to do anything. And what is probably more useful is a referral to either a rehabilitation program, be it cardiac, be it physical medicine, or to a medical fitness center where trained professionals are able to give specific advice that's geared to that individual person's problem. And so it'd probably be better if the physician or the last healthcare provider who sees the patient upon discharge from the hospital or a visit in an office make a referral. That would be more useful than just say, go exercise more.
Does anyone pay for this? Because I suspect that there are a lot of cancer patients, and I'm thinking now in particular of prostate cancer patients who have perhaps taken hormone-suppressing medications and their muscles are atrophying. where they would actually like to have some kind of organized program, maybe centered around a cancer center, and who's going to pay?
Well, that's one of the challenges that we also face. Now, I can talk more to patients with cardiovascular disease because that's what I do specifically. And there is insurance reimbursement for rehabilitation. Or in many other conditions, people may be able to get coverage if they're referred to physical therapy or physical medicine. But there's no consistent payment program across the board except in certain conditions like the few I mentioned.
So this would be another advantage to having the doctor actually refer the patient, that conceivably the patient's insurance might reimburse some portion of the expense.
Correct.
Now, you talked about cardiac rehabilitation, and we have recognized that after a heart attack, people definitely benefit from very structured exercise programs. What about preventing heart attacks? I mean, wouldn't it be helpful to use exercise to prevent heart attacks? Are there any programs for that?
Well, so I think the programs, there's not a specific program per se to prevent a heart attack, but it is important to exercise to help prevent heart attacks. And, I have found, just to kind of point out the gravity of how important this is, the CDC actually has pretty good information on their website. It's become a public health issue as to some guidelines as to how much you should exercise. And I think sitting down with the patient and going through, for example, you have a younger patient in their, let's say, 40s or 50s who has a significant family history of coronary artery disease. I think it makes sense to sit down with them and explain to them that this is actually a treatment equivalent to, or perhaps even better than some of the medications we offer in these situations. So I think, again, it takes time to do these things in a patient visit, but I think it's important preventatively. And again, the CDC, I believe they recommend 2.5 hours of moderate intensity aerobic exercise weekly. And, to get there, 7 days a week, you can just sort of sit down with the patient and say, look, if you're getting 3 10-minute periods of brisk walking in a day, you're sort of headed towards that direction. And I think that's where it boils down to. So I wouldn't say that there's a specific exercise program that prevents heart attacks, except to say that an exercise program in itself regularly for a period of time has been proven to prevent coronary disease.
Dr. Dixit, there's been a bit of controversy over the last couple of months regarding step counting. And there was this article that was published, I think even in the medical literature, about the magic number of 10,000 steps, that if you weren't getting 10,000 steps every day, you weren't achieving your goal. And someone said, oh, hold everything. That's sort of a mythological number. I mean, if you're getting 6,800 steps, it's still doing something. Can you give us some sense of what we should be striving for? I know that you're an advocate of individualized or personalized medicine, but a lot of times people like goals.
Yeah, so I think going back to that individualized sort of plan, if someone is getting 1,000 or 2,000 steps a day, that's probably not enough. And so whether they get to 6,000, 7,000, 8,000, or 10,000, it's the goal is to get much better than they are. So I think with those studies on the steps, and Dr. Stewart's sort of a world expert on this, but I would say in general, I don't think there's a magic number they've come up with that makes sense for everybody. I think 10,000 is an easy number. It's an easy number to look on your phone and say, look, I'm getting 10,000 steps a week, and maybe that's how we've come to that. But I do think in general, again, I wouldn't give a hard and fast number as this is what applies to everybody. But if it's clear that someone is not exercising, it's easy. And then if somebody is getting a moderate amount of exercise and still has these risk factors, then you kind of sit down with them and say, what else could you be doing? Could you increase your steps if you're at 5,000 or 6,000 or something?
Now, the 10,000 steps aligns kind of nicely with the CDC guidelines that were mentioned. And even though it probably started out as an arbitrary number, from a behavioral perspective, which is, what we often have to do, is how do you get people to change their behavior by setting a goal of 10,000 that motivates an awful lot of people.
So you see that as a very positive thing. Do fitness trackers help?
Oh, absolutely. To the extent that they motivate people to move, that's good.
Dr. Stewart, I suspect that a lot of people, after they've had a big event like a heart attack, and the cardiologist gives them the talking to afterwards and says, you really do need to exercise and do it regularly. People are more motivated than they were perhaps before that event. How do we keep that motivation going after 6 weeks, 6 months, 3 years, so that it really does become incorporated into their daily routine?
Well, like I said, to sustain exercise over time, behavior needs to change. And to the extent that participating early becomes a habit, that'll more likely lead to long-term adherence. So, and people start losing weight, they feel better, they're less out of breath, they can do more, they can enjoy more activities with their family. Then they start seeing the benefit themselves more than just some parameter that the doctor says is important for you.
Dr. Stewart, I'm going to read you a little quote that we have. I'm quoting you.
Oh, good.
Yeah. At the,
I hope it was accurate.
Well, we'll find out. It was at the 2018 Exercises Medicine Symposium, and you said, much of precision medicine relies on genetics. Our vision is we'll rely a lot more on gym therapy rather than gene therapy. Can you tell us more about that? And was it accurate?
Well, I did say that, and I often use that play on words because I think it reveals a lot of what the state of medicine is in many ways. And with this big interest in precision medicine, which also relies on doing genetic analyses and coming up with genetic therapies, that's where medicine seems to be moving. But it hasn't moved that far yet where it's available to a large number of people. But what is proven to be beneficial and is available to a large number of people is gym therapy. And so I think there's a lot of truth to that statement. That gets attention to people when I say it that way.
Yes, it does. I want to ask you about another topic that affects a large number of people. A lot of people would like to lose weight, and they say, well, if I exercise more, I'll lose weight. Sometimes they're disappointed. Tell us a little bit more, if you can, please, about the connection between weight loss, exercise, what people can expect, and how they should actually go about incorporating exercise into a weight loss program.
So what I think is pretty clear from the literature and my experience is that in the short term, the way to lose weight is to change diet. And that typically means either changing the types of foods that are being used or specifically cutting down calories. At the same time, it's important for people to begin an exercise program. But what's pretty clear is that exercise, weight loss maintenance is helped by exercise in the long term. But in the short term, diet needs to change to lose significant amounts of weight.
So it's a kind of 1-2 punch, if you like. They really need to go hand in glove.
Correct. But in the short term, the diet needs to change. You can't just go out and walk a mile and expect a pound of weight to be lost. You'd have to walk 15 or 20 miles to lose a pound, which is not realistic.
Not realistic.
No, and if you go out and walk that much, you might be more hungry when you finish.
Possibly.
Dr. Stewart, there are a lot of conditions that I think our listeners worry about, but there's one in particular that gets everyone's attention these days, and it has to do with cognitive function, dementia, Alzheimer's disease. And as far as we know, there is no treatment that is currently available that will do much to prevent or alleviate the symptoms of dementia. But exercise looks very promising. Can you tell us a bit about your research and what your colleagues are coming up with?
Oh, I think the research and the literature on that is still accumulating, but the results seem to be pointing in the direction that exercise can help with cognition and potentially delay symptoms of dementia. But I wouldn't say it's a definitive treatment at this point, but there's no reason not to do it, and the evidence suggests that doing it can be helpful.
There are certain kinds of exercise that seem to be helpful for certain kinds of conditions. For example, we've heard that very intense stationary bike riding can be helpful for people with Parkinson's disease, as can, of all things, boxing. Can you tell us a little bit about personalized exercise programs for particular problems?
We're kind of looking at each other, but I can speak a little bit about the Parkinson's issue. So the boxing actually is helpful for Parkinson's because when someone is boxing, they're always challenging their balance and agility. And so to maintain good agility and good balance, you work out in an activity that challenges that, and the result is you become better at doing it. I would doubt that stationary bicycling would be very helpful because it's stationary and there's no challenge to balance, which is obviously a problem in people with Parkinson's disease. Similarly, I think walking on a treadmill would not be as useful specifically for symptoms of Parkinson's. Now, people who have Parkinson's should be walking on treadmills or riding bikes to try to get some aerobic benefit. But for their specific symptoms, which is to try to prevent falls and maintain balance, activities like boxing would be helpful.
Dr. Dixit, you had something to add, I think.
Yeah, and I guess that bit about Parkinson's I wasn't familiar with, but I don't think we know of specific exercise programs for specific diseases. It'd be great. Outside of what you just mentioned, I've never heard of that. So I think we kind of put it in categories of aerobic versus muscle building and things of that nature, where we have certain exercise programs we know help with certain disease processes. For example, aerobic exercise can help with a lot of these cardiovascular issues that we're talking about, but there are certain forms of exercise that are, such as muscle building, that are better for certain medical conditions that we see, for example, prevention of falls and things like that. So I think as we sort of proceed in this realm, we probably will be able to say, hey, this is what you should do for this disease entity, but we kind of look at look at this as from a higher view than saying this is the specific activity you should do for this disease right now.
Well, let me just say that we're actually involved now in a clinical trial looking at fall prevention in older people. About 1,200 people are currently enrolled, and we're testing a program that focuses specifically on balance and coordination exercises and other exercises using bands to try to increase muscle strength and perhaps improve bone health as a way of preventing falls and fractures. Even though we recommend walking for general fitness purposes, we don't believe the walking is really the key to this program. It'll be the exercises that are focused on the deficiencies that people have that lead to falls.
You're listening to Dr. Carey Stewart, Director of Clinical and Research Exercise Physiology at Johns Hopkins University School of Medicine. He's also Professor of Medicine in the Cardiology Division. You're also listening to Dr. Samir Dixit, Medical Director of the Johns Hopkins Orthopedic Clinic at Green Springs Station. He is Assistant Professor of Orthopedic Surgery at Johns Hopkins School of Medicine.
And Terry, there actually is some research to suggest that high-intensity biking or using a stationary bike can be helpful in Parkinson's disease.
Absolutely.
After the break, we'll focus on the physical and psychological aspects of injury in athletes.
How do medicines like ibuprofen affect healing from an injury?
Many athletes get corticosteroid injections into sore joints. What are the pros and cons of this practice?
What about injections of platelet-rich plasma? Can that help injuries heal more quickly?
We'll also discuss the research on doctors monitoring exercise regimens to help fine-tune them.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
This People's Pharmacy podcast is brought to you in part by Verisana.com.
Verisana Lab offers home health tests that allow you to monitor your hormones and health conditions. You can take control of the quantitative assessment of your health and learn about male and female hormone balance, the stress hormone cortisol, leaky gut, gluten intolerance, or your gut microbiome.
Take a more active role in tracking your health and take 20% off your first order of a mail-in testing opportunity with the discount code PEOPLE. That's uppercase PEOPLE. To learn more, go to Verisana.com. That's VERISANA.com. Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Cocoa Via, offering plant-based nutrients in the form of cocoa flavanols for brain and heart health. Online at cocovia.com.
And by Kaya Biotics, probiotic products made in Germany from certified organic ingredients. KAYA Biotics.com.
For athletes, even weekend warriors, being sidelined can be psychologically devastating. How can injured athletes heal more quickly so they can get back to their game?
Our guest, Dr. Carrie Stewart, is Director of Clinical and Research Exercise Physiology at Johns Hopkins University School of Medicine. He's also Professor of Medicine in the Cardiology Division.
We're also speaking with Dr. Samir Dixit, Medical Director of the Johns Hopkins Orthopedic Clinic at Green Spring Station. He's Assistant Professor of Orthopedic Surgery at Johns Hopkins School of Medicine.
Dr. Dixit, your research interests focus on comprehensive medical care of athletes. We happen to know quite a few athletes, and what I've discovered, especially with my tennis playing partners, is that when they experience an injury, perhaps to a knee or a shoulder, an elbow, they become very depressed because they really feel like, that's my activity, that's what I love, and if I can't play tennis, my life, it's not over, but it really is less fulfilling. And they don't take up biking or they don't take up swimming. It's like they're just waiting for the surgery and then waiting for the recovery so they can get back into playing tennis again. So how do you help with two aspects? One is the physical problems of athletes who can't do what they love, but then the psychological effects of not being able to do the things that you really enjoy.
Yeah, that's a very good point, and I think so. I'll address the physical first. I think each injury is kind of has a different timetable for recovery. So I think we often, if it's something that requires rehabilitation, which is often the case, we kind of work with our physical therapists on getting them to do activities that sort of mimic the sport that they're playing. And that it kind of piques their interest. It gives them some form of the same physicality they're used to having in their life, when that kind of segues to the second part of your question. And absolutely, the psychological aspects of an injury are something that we see and we deal with really on a daily basis in our clinics and our training rooms. And I think first it's important to recognize and acknowledge that this is an important part of an athlete's life. And then the second thing is to kind of discuss with them what options they have within the injury that they have. So you're right, it's hard to turn a tennis player into a swimmer if they're not interested. But I think you can sort of you can kind of brainstorm with them and see what other options they have. Sometimes with my singles tennis players, I will encourage them to kind of pick up doubles for a little bit if they can, depending on the injury, so they can sort of stay close to tennis, even though it's not exactly what they're used to. So you specifically mentioned tennis, but I think it depends on the sport that they're playing. And then there are times when they don't have the option to go back to the sport in the timetable that that's appropriate for them. And rarely we can get folks involved who can help them with that, whether it be a therapist or somebody to talk to, and because these are legitimate concerns, and this is how we say exercise is medicine. Exercise is specifically medicine for depression and mental health issues, and I think it's important to acknowledge the importance of exercise and treatment of those issues or prevention.
Dr. Dixit, what are some of the recommendations that you make? Because I think a lot of weekend athletes rely on nonsteroidal anti-inflammatory drugs as their vitamin, kind of vitamin I for ibuprofen. We know that there are some complications with self-treating with NSAIDs because you can buy them over the counter. People think of them as pretty benign. What else do you use besides drugs like Advil or Aleve or whatever to help people recover from whether it's a sprain, a strain, or something more severe?
Well, I mean, I think the first point is that nonsteroidals are not benign. I think I make that point very clear. And in the injuries that we deal with in sports medicine, they're not treating the injury per se. They're treating your symptoms of the injury. And so if the pain or the swelling, for example, are uncomfortable enough that that the patient wants to have their pain or swelling treated, I think it is important to treat it and give them medication. But I make it pretty clear to my athletes that ibuprofen is not vitamin I, and it is not just a supplement, that it has the potential to cause harm, and therefore it's a risk-benefit. And if the benefit of the medication in the setting of an acute injury or a chronic injury is worth the risk, that's an individualized decision. So I think that's the first point. The second point is in terms of how else we can treat it. If it's an acute injury, we have sort of good old ice. We use a lot of the time to help people with their pain. We work with our physical therapists. We have some pretty sort of fancy gadgets in our physical therapy area that include sort of various modalities that can help people with pain in particular. So and they have techniques that our therapists use to help them with their pain too. So I think that's sort of a broad answer because it's sort of a broad question. But I would say there are a lot of techniques we can use to help people with pain outside of medicine, and it's okay to take a medication if you need it for your pain, but I think it's important to explain to your patient the risk of taking medication.
I know that when I broke my wrist several years ago, the physician said, well, you can take a nonsteroidal anti-inflammatory drug if you need that pain relief, but try to minimize it because it may interfere with the healing of the bone. So that was something that was important to me. I wanted my bone to heal as quickly as possible.
Yes, and it's the same advice I give my patients as well. I mean, there's been pretty good animal studies that have showed a delay in bone healing with fractures. I think it's harder to show in humans, and I think certainly anecdotally most people who take nonsteroidals heal fine. But I think if you don't have to take it, you shouldn't take it.
Could we talk just briefly about injections of corticosteroids? A lot of my tennis partners, I'm coming up on my 3 months. I'm going to get another steroid injection, and then I'll be good to go for a while longer.
This is certainly a popular intervention, but is it helpful?
I think corticosteroid injections can be helpful to relieve pain. They are not curative. They don't alter the long-term course of, for example, arthritis, which is often let's talk about knee arthritis, for example, and that's something that's very common to use in tennis players to get them relief. So I think every 3 months, I would say most of us probably don't do more than 3 corticosteroid injections a year in a patient in a joint. And it's only for pain relief. I make that very clear to our patients. It doesn't really help the healing process or turn around the healing process of the knee. It's a opportunity to try to get them through their life. And what I tell my athletes is that it's not a good way to get back to playing. I think if you're having trouble with your activities of daily living, it's probably a reasonable option short of, and again, using the example of knee arthritis, short of a knee replacement to get you through. However, if you require a steroid injection just to get on a tennis court, that's probably not a good long-term solution to your situation. And, you kind of need to work with other forms of treatment. We talked about weight loss. Sometimes weight loss can help. We talked about rehab. Sometimes hip or core strengthening or quad strengthening can help. So I think working with your patient on getting them back on, because again, we talk about how important activity is important, but I don't think steroids aren't a magic fix to get them back there for the long term.
Do those steroid injections have potential negative consequences?
So potentially, yes. I think it, again, depends on the situation. They are degradative over time. Steroids are degradative over time. So in theory, they could be a deleterious effect. I think practically speaking, if someone already has an arthritic joint, the degradation process has already started. And I don't know that we haven't studied well enough whether this accelerates it or not. I think there are other sort of forms of treatment that are more in an experimental phase that people are looking at to see if we can reverse the process, but they haven't been proven to do so yet either.
We hear a lot about something called platelet-rich plasma injections. Is that what I'm hearing correctly? And are there any other new approaches to helping people get over an injury faster or an arthritic problem?
Certainly, platelet-rich plasma is something that is used in sports medicine clinics quite frequently these days to help people with an injury. It's a process whereby they take your blood and, kind of simplifying it, they spin it down in a centrifuge and inject the platelet-rich plasma layer into the area of concern. It has been shown to be in certain disease entities as effective as steroids for relieving pain. What has not been shown, to my knowledge, to this point is that it reverses the process. And so similarly, they're looking at various forms of stem cell injections and things of this nature. And at this point, none of them have been shown to reverse the process of aging.
So you'd have to say the research is inconclusive at this point, or it's conclusive that it doesn't help?
So I would say inconclusive is probably more accurate. I think, and again, it depends on how you're interpreting the data. It has been conclusively shown to help people with pain, but no better than some of the other things we use commonly, like steroids and things like that. It has not been shown conclusively to reverse the process of these disease entities that we're talking about.
Dr. Stewart, I'd like to get your perspective on what I call mutual support. So if it's too hot and humid, or if it's too cold and nasty out, a lot of times people go, I'm not going to even walk today. It's just too unpleasant out there. Or I'm not going to go to the gym.
But that's if they don't have a dog that needs to be walked.
Or a friend who's waiting for you to meet at the street corner. So could you give us some insight on the benefits of support, whether it's Fido and his wagging tail, or whether it's Fred and he's dressed in his gym clothes and he's ready to go?
I think it's been shown pretty clearly that having some social support network, be it a friend or joining a group like the cardiac rehab program or joining a gym or having Fido, does motivate people to exercise where they otherwise might say, I'm not doing it today. So I think it's very helpful.
What about electronic gadgets? I mean, whether it's an Apple Watch or some other device, there are now lots of ways of sort of monitoring your exercise and also getting some reinforcement. Terry, on her Apple Watch, gets messages usually fairly late at night.
It says, you haven't met your exercise goal for today. Take a brisk 15-minute walk, which would be a great suggestion if the watch gave it to me at maybe 6:30 or 7 o'clock in the evening. But at 10:30 or 11 at night, it's not so helpful.
I would say, using the term that Dr. Dixit used, the research on that is somewhat inconclusive at this point, that these devices and getting feedback electronically through messaging, as you mentioned, is particularly helpful. There's a lot of studies going on looking at that, but they're not conclusive in terms of it being any better than just taking your dog out for a walk.
What about doctors? I mean, a watch is a little impersonal. So when your watch tells you, at 10:30 that you need to take a 15-minute brisk walk, it might not be motivating enough. But if your doctor was monitoring your exercise regimen and could say, "Hey, Joe, I noticed that you're hitting that 7,000 step mark on a pretty regular basis, but it would be so much better if you were, upping that ante to maybe 8 or 10,000 steps a day." And having the doctor as the, I hate to say it, but the authority figure who's keeping track of your progress might have a little more impact. Any research in that area?
Yes. I actually did a study in that area about 3 or 4 years ago where we took a group of overweight and moderately obese women and put them in a study where we gave them Fitbits and cell phones, and we randomized them to a group that just got plain text messages reminding them about they needed to walk that day versus giving them what we called multimedia messages, which included video clips from the therapist that was working with them saying, you met your goal today or you didn't meet your goal today. And all the messages were crafted based on what the person did. And at the end of the day, there was actually no difference between the two groups in terms of the amount of walking that was actually done. So we haven't seen that outcome yet.
So essentially what you're saying is it's inconclusive whether having your doctor actually be in touch with you would make any difference at this point.
I mean, we thought we had a great hypothesis to test and hope prove, but it just didn't work out.
In sum up, can you both tell us about the importance of exercise as medicine and what we should be doing about it?
Sure. I think, in terms of exercise, I think one of the things to stress to healthcare professionals as well as our patients is that a way to not see the doctor down the road for a medical issue is to exercise and make it a regular part of your life. So it really is, from my perspective, a preventative tool that can keep you from having to take medications and expose you to the possible risk of medications or even more procedures and things that we perform on our patients. So I think it is very important to hit that message with every patient that you see when you have the time to do so.
Now, we used the term a couple of times now, the research is inconclusive. But I think this is an area where the research is definitively conclusive, that people who are engaged in physical activity, either if they start as kids and continue till today, or if they start later in life, have an advantage of having a reduced risk of many diseases. And so it's important for people to keep moving. That's conclusive.
Great. Dr. Carrie Stewart, Dr. Samir Dixit, thank you so much for talking with us on the People's Pharmacy today.
Thank you.
Thank you.
You've been listening to Dr. Carrie Stewart, Director of Clinical and Research Exercise Physiology at Johns Hopkins University School of Medicine. He's also Professor of Medicine in the Cardiology Division. We also spoke with Dr. Samir Dixit, Medical Director of the Johns Hopkins Orthopedic Clinic at Green Spring Station. He is Assistant Professor of Orthopedic Surgery at Johns Hopkins School of Medicine.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is brought to you in part by Verazana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
And by CocoVia, the maker of high-potency cocoflavanol supplements that support cognitive and cardiovascular health. More information at cocoavia.com. That's COCOAVIA.com.
To buy a CD of today's show or any other People's Pharmacy broadcast, you can call 800 800-732-2334. Today's show is 1182. The number again, 800-732-2334, online at peoplespharmacy.com.
And when you visit our site, you can share your thoughts about today's show. What's your exercise program? Has it helped you recover from an injury or an illness? Please tell us about it.
At peoplespharmacy.com, you can sign up for our free online newsletter or subscribe to the free podcast of the show. You'll never miss another episode again, and you can share it with a friend.
When you sign up for the newsletter, you also get our free e-guide to favorite home remedies.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thanks for listening. Please join us again next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money.
If you like what we do and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in.
All you have to do is go to peoplespharmacy.com/donate.
Whether it's just one time or a monthly donation, you can be part of the team that makes this show possible. Thank you for your continued loyalty and support. We couldn't make our show without you.